a provider or first provider. There will be written tests on these skills and go over everything, National Registry. By the end of this lesson, you should be able to describe the major function of first responder providing emergency medical care. Learning objective is to describe the role of fire service in providing emergency medical care. Upon successful completion of this lesson, the student shall be able to describe the role of fire service in providing emergency medical care. Explain patient confidentiality requirements per the NFPA 1001, 6.11, 6.1.2, 6.2.1. Identify communicable diseases that first responders commonly encounter. Explain why there are ways to prevent special spread of communicable diseases during emergency medical care. Explain process of patient assessment. Describe cardiopulmonary resuscitation, or CPR. Describe methods of bleeding control. Explain shock management. First section is going to be fire-based emergency medical care. Fire-based emergency medical care, or EMS, usually treatment on scene and transport to victims to the ambulance. They will show up with first EMTs and paramedics and treat the victims there, or they'll transport them to the closest medical facility. Fire service has a big key in providing emergency medical care since the inception of the EMS. The first responder will provide EMS in a number of ways. Even if the organization does not operate ambulance units, its personnel often serve medical first responders to provide treatment until an ambulance arrives. So, first responders, they get there, they're trained, certified first responders, they are able to get vital signs for the EMTs and paramedics and oncoming ambulances, treat for basic life support situations, maybe cast or splitting a broken arm or broken wrist, bleeding control, little minor, simple, basic life skills until the ambulance arrives with EMT and paramedic. The ambulance services typically provide in one of the three following ways. They have a fire-based EMS, which ambulance services provide as function of the fire department. You see that a lot in the city. See like Kansas City, KCFD, Inner City Fire Protection District, Fort Osage Fire Protection District. They have their own ambulance assigned to the fire station. Where Independence Fire does not, they contract with AMR. So AMR is the medical provider in that fire district. Some rural areas, I know Dearborn up in Black County, at one time had built an ambulance bay and started manning their fire station with their EMTs and paramedics to respond. And they were a volunteer department, so they didn't man that station other than the EMS. Staffing is typically provided by firefighters who have been cross-trained as EMTs or paramedics. In other jurisdictions, the fire department sometimes provides ambulance service, but not EMTs and paramedics who do not have firefighting responsibility to provide staffing. So that's what we're just talking about. They're up there at Dearborn and have no fire experience. 90% of them up there are cross-trained as well, because they start out at a young or a volunteer and decide they want to go into it. Hey, let's get into the EMS. The third service, EMS, is an organization that separate from the fire and police service, has its own administrator, provides ambulance service, so it's like American Medical Responder up in the city, AMR. In most instances, this organization is a function of the municipal, county, provincial, or regional government. In some jurisdiction, a for-profit or not-for-profit organization that is under contract may provide the service. Then you have the hospital-based EMS. Golden Valley is a hospital-based EMS. They have their own ambulance, and they provide their own EMTs. John Knox, only some that I know, has their own ambulance, and so the benefit of that is something happens in facility, you have on staff right there, and then they don't have to wait for an oncoming ambulance to get there, and then go to another medical facility they can treat and then personnel work at the hospital. Ambulance services contracted to the hospital by local government. Patients typically transported to the contracted hospital for treatment. Regardless of type of ambulance service provided in your jurisdiction, become familiar with the equipment, protocols, and standard of care use. So I know before Intercity started its ambulance district and got its ground ambulance license, for us to help A&R load patients into their ambulance, we had to do a 12-hour shift with that, with a crew to learn how to operate their cots. They have auto cots, they have manual cots, which are way better. In areas where the fire department does not provide ambulance services, it's especially important that firefighters train regularly with EMS personnel and the unions have a good working relationship. And it really is, if we can help Warsaw Lincoln get a patient or transport or get in the back of that ambulance with them and help provide care for that patient until they get to where they need to be, until life flight gets them, the chances of living is better than not. In many jurisdictions, fire department can respond to an emergency medical call faster than EMS. Typically, fire's there before EMS. It depends on how busy the EMS is. If they're blacked out, they have to call neighboring services. Here, I think it would be Coal Camp, right? Yeah. And if Coal Camp's blacked out, then they're going to go to Pettis County. So there's a lot of if factors in that, and that's why it's important for firefighters to be cross-trained as medical responders as well. In most areas, there are multiple fire stations and apparatuses, but very few ambulances. Some areas routinely have more medical calls than available ambulances. Fire departments are often requested to respond and begin care until EMS arrive. I've been told here that they really only call out us if they need lift assist. So hopefully in the future that changes and we start running calls and responding simultaneously. I know down here you get a lot of weekenders and they come from the city where 911's called, you got fire, EMS, and ambulance all on one call. Some departments provide this EMS service to personnel who have limited EMS training. Others provide fully functional paramedics who carry most of the same equipment and medication on the fire apparatus that are carried in the ambulance. What roles does the fire department play in providing emergency medical care down here?
The helicopter.
So you guys set up helo pads, right?
Landing zone, is that?
Yeah, landing zones.
I would like to comment on the fact that sometimes the fire department is there first to communicate with the ambulance and give them information about what type of situations they have, what type of injuries they are.
Yeah, and ideally that's the way.
That way they'll know whether to expect a second or third ambulance
Right.
to call all the time.
That's absolutely the way it should be.
You don't administer CPR to someone that's not breathing. Is that the only time you do it? There's a,
Not that they're just not breathing. They have to be unresponsive, pulseless. Because even rescue breathing is part of CPR. And that's someone who has a pulse of less than 60, but having difficulty breathing. So you might put a bag on them and start bagging them and count 1 by 36 seconds. what level of emergency care does fire department provide in your jurisdiction? Lesson 2 is going to be patient confidentiality, HIPAA, which is the Health Insurance Portability and Accountability Act of 1996. The HIPAA is a law that regulates the use, distribution, and storage of patients' protected medical information, PMI. It establishes civil and criminal penalties for non-compliance. Fire departments are typically required to follow HIPAA if they provide medical care and bill electronically for services. Regulations dictate how and to whom PMI can be shared. HIPAA dictates how PMI is to be protected from unauthorized disclosures. Departments must have design privacy officer that provides compliance training. So, a lot of people had scanners before we went to the digital age. Would hear everybody's information. If it's public information, that's not a HIPAA covered, like name, address. You can look that up, it's public information. So that won't be covered by HIPAA. But if I'm in an ambulance and I'm on the radio, or maybe I'm on the phone with my wife and I got her on speaker, I'm like, I know Kim, and I'm giving my wife Kim's medical history, what's going on, that's a violation completely. Protected medical information, you have to be discreet. Only disclose PMI to those with a legitimate need. Now,
Like a healthcare provider or family member?
not necessarily a family member.
Really?
Because, again, unless they have portable power of attorney, which is only going to let you know what hospitals to give them and what medications to give them or something along that lines. But definitely healthcare providers that you're passing that patient off to. Let's say you're a nurse, but you're not Kim's nurse, and I'm talking to you about Kim's diagnosis. That's a HIPAA violation because you have no reason to be with her. You're not attuned to that patient. So
So
it's
the exception to that if they were working together as a team?
yes, that's different. When and a lot of police officers will come up and ask questions, and technically, you don't have to give that information to them unless you're subpoenaed.
Well, let's just use this angle here. Jim's a patient doctor, knows that, and he could go around Warsaw and say Jim's my patient. That's a HIPAA violation, correct?
Without Jim's permission.
Yeah, okay, I thought it was. I think it's like, to even say that someone is a patient,
Mhm.
or we treat them is a HIPAA violation.
Yeah, absolutely. The release of PMI to others can only be done with patient consent. So you have an unconscious patient and family member wants to know information, you can't do it unless they say, hey, yeah, it's okay. Become familiar with the departments having jurisdiction guidelines, or authority having jurisdiction guidelines. In the United States, the HIPAA is instituted greater regulations on the use, distribution, and storage of PMI. It established civil and criminal penalties for non-compliance. Fire departments typically required to follow these regulations if they provide medical care. Regulations dictate how and to whom it can be shared, how information is to be protected from unauthorized disclosure. If your department is bound by HIPAA regulations, the department must have a designated privacy officer that provides compliance. Regardless of the department's obligation under HIPAA, it is a good professional practice to be discreet with PMI. Individuals who often have need for this information is law enforcement personnel, only if it is in regards to the incident they're working. EMS personnel, hospital staff. Release of PMI to others can only be done with patient consent. You should become familiar with and adhere to guidelines that the department and authority having jurisdiction established. Who has the right to access patient medical records?
Medical professionals.
Do you have the right to get your own medical records?
Patient name.
Yeah. No, it's a sunshine law. You have 24 hours, I believe, from the date that you requested to get it. Learning objective 3 is going to be infectious control. What the objective is to identify communicable diseases that first responders commonly encounter. You may be called upon to provide medical care to patients with communicable diseases. Communicable diseases are not always obvious. It's a great risk. You can greatly reduce the risk of infection with the ability to identify the signs and symptoms of common communicable diseases, use of proper body self-isolation or BSI procedures, or PPE. BSI and PPE are the same thing. Fire side calls it PPE, medical side calls it BSI. It's the barrier between you and the disease. And then stay up to date on your immunizations. Commonly encountered communicable diseases, hepatitis. It's inflammation of the liver. It's viral hepatitis is the most common, but drugs, alcohol, hazardous chemical, and hereditary can also cause the disease. The symptoms include hepatitis A is typically caused by consuming contaminated food or water. It can be transmitted by close contact with infected individuals. Signs and symptoms are fatigue, abdominal pain, fever, dark urine, yellowing of skin or jaundice, and or eyes. Typically no longer consequences. Typically no long-term consequences. This is the least severe of all the hepatitis.
Is hepatitis usually
It can be. It can also be. There's Hep C is airborne, I believe. So you're just being in the same area with somebody. You see a lot of military, prison, or jailers. They'll get it because they're in such confined areas. Hepatitis B is typically transmitted through bodily fluids. That's going to be your junkies. Infection can be short-term or long-term. Can cause serious scarring and injury to the liver. Can progress to liver failure. Signs and symptoms resemble hepatitis A. Serious potential lifelong infection. Hepatitis C is typically transmitted through bodily fluids. Individuals can go for many years without exhibiting symptoms. Liver damage can be long-term or permanent. Liver failure can occur. Hep D is a very uncommon strain. It only occurs in individuals infected with hepatitis B. Makes effects of hepatitis B much worse. Vaccines available for Hep A. There are vaccines available for Hep A and B. Remain in development for hepatitis C. Firefighters would be immune against hepatitis and other infectious disease. Thoroughly wash and maintain proper BSI procedures. So it's important that you wash your gear often. And make sure that you clean yourself as deep clean as you can. Tuberculosis or TB. The best way to combat hepatitis is by thoroughly washing your hands and maintaining proper BSI procedures. Tuberculosis or TB is a bacterial infection that primarily affects the respiratory system, contagious and airborne. That's exactly TB, so you get your TB shots.
Get that on airplanes.
Yeah. Spread when an infectious person breathes, coughs, or sneezes on them. Incidents are more prevalent in high density living areas considered active when individuals exhibit signs and symptoms. Here's your signs and symptoms of TB are fever, fatigue, chills, weight loss, painful breathing, and productive cough for the last several weeks. TB can be disguised as a bad respiratory problem, being cold, you're coughing. Chances are you could have TB, so it's not bad. Get your TB test and do it annually. Precautions in testing, BSI precautions, use an N95 mask even if the patient is not known to be infected. So N95 masks are not the ones that you just go to the store and buy. N95 masks are actually sized to your face. Just an FYI. No widely used vaccine. Annual skin test to check for exposure. Annual purified protein derivative (PPD) test to determine the exposure. Medical equipment and surfaces should be decontaminated immediately following soiling to prevent the spread of infectious disease and responders to other patients. HIV and AIDS. Prolonged exposure to HIV equals AIDS. HIV and AIDS weakness in the immune system to the point where the body is unable to fight off diseases. Early symptoms are similar to other viral illnesses. Advanced stages lead to severe muscle wasting and increased likelihood of contracting other infections. Persons with HIV are likely to have diseases such as hepatitis and TB. HIV and AIDS is spread through contact with the infected blood and body fluids. Less risk of responders than hepatitis and TB. There's still a chance if you accidentally stick them with their insulin needles, or you forget to put your gloves on and have open wounds and body fluids are exchanged that way. It's important, if that happens, to tell your supervisors to go immediately to the primary care and get tested just to make sure. It's important to practice proper BSI procedures and decontaminate your equipment. Go ahead and take a break. Take a 5-minute break. We'll be back here at 7:07. Okay. Multiple drug resistant organisms, or MDROs. They are difficult to control, typically do not respond to conventional antibiotic treatments. Drug-resistant staph infection, or MRSA, are common. Typically occur in healthcare settings that can outbreak in communities. Usually initially seen as skin abscesses, spread easily. They take proper BSI precautions and sanitize all usable medical equipment after each use. Your other diseases. Recent outbreaks in North America include H1N1 influenza, or swine flu, the avian influenza, the bird flu, and others. Be prepared to treat infected patients. Proper sanitation and BSI procedures will help keep you and patients safe. test and treatment for communicable diseases. If exposed or possibly exposed, follow your SOPs for testing or treatment. What are communicable diseases that first responders commonly encounter? Hepatitis. AIDS is the less common we have. AIDS, yeah, TB and hepatitis. 4. Explain ways to prevent and spread the communicable disease during emergency medical care. Immunization seems to be the beating the pattern. Get
Wash your
immunized.
hands and wear a mask.
Yeah. If you're infected, wear a mask. You may be required to be immunized against certain infection diseases, like influenza, MMR, tetanus, chickenpox. Your body substance isolation, BSI, pathogens, organisms that carry disease and can cause infection, exist in body fluids in infected persons, transmitted through contact with infected fluids, bloodborne pathogens, and most common but airborne are also a big threat. Exposures occur when body fluids of infected individuals come in contact with the exposed area of another person. Routes of exposure, the way you get exposed through your wound or your communicable diseases, contact with eyes, nose, and mouth, open wounds, cut sores, any break in the skin. Your elder are more likely to get those communicable diseases because their skin is more brittle than ours. The best way to prevent it is to take all precautions necessary for protection: hand washing, proper use of PPE, proper disposal and or use of cleaning soil, proper disposal and or cleaning of soiled items. Sources of information is the U.S. Center for Disease, or CDC, the Canadian Provincial Health Authorities. Hand washing greatly reduces the transmission of communicable diseases. Should be done frequently. Wash methodologically with warm water and soap. The old saying was, say your alphabet, sing your alphabet to you, do the whole alphabet song. And that should be about 26 to 30 seconds worth of washing. Sometimes you make sure you get up to your elbow if you need to, depending on where you're exposed or the possibility of exposure would be. Pay special attention to soiled areas between fingers and fingernails. So I try to keep my fingers really small. Hand washing, wash wrist, forearm, scrub. Special scrub pad may be used. Wash for at least 30 seconds. Alcohol-based cleaning solution can be used when hand washing is not possible. Your personal protective equipment or PPE. Use adequate PPE to prevent transmission of infection diseases. Adjust level protection based on potential threat of infection. Jurisdictions will dictate level of PPE worn on medical calls. Too much PPE is better than nothing at all. Wearing your gloves. Gloves should always be worn during patient contact. Latex or vinyl. Use non-latex gloves if the patient has latex allergies. Most agencies have went to non-latex gloves because there are patients that are allergic to latex. Remove your gloves and don a clean pair when moving from one patient to another. When you remove your gloves, you want to make sure you're moving to not cross-contaminate. So you pull one, take it halfway off, put it in that glove, fill it, slide it, turn it inside out.
You ever wash your hands before you go on?
I do, if able. If not, I'll take some hand sanitizer and put it on. Proper way of removing. So the proper way to remove your gloves after you've soiled, you'll pinch the outside, pull it halfway. So this is non-contaminated, right? The contamination is on the inside. You'll take that, pinch it here, pull it, clean hand, slide it up under where it's non-contaminated, and turn it into a trash bag. Then you dispose of it properly, give it to ambulance and put it in a biohazard bag. Or some of the fire trucks should have biohazard bags as well. Eye protection. If you wear glasses, that's a barrier device, but if you want to make double safety, go ahead and get another pair of safety glasses. Eye protection is necessary when blood or body fluids can be splashed, sprayed, or spattered. Safety glasses keep fluids away from your eyes and provide impact resistance. Accessories are available for those who wear protection glasses. Combination of mask and shield. Helmet shields are work eye shields. Do not provide suitable protection for emergency medical. So the visors that are on your helmets, they're saying are not suitable shields for eye protection to keep it splattered.
Those are heat shields.
Right. Mask. Protect against respiratory hazards, airborne pathogens, and body fluids. Surgical masks typically suffice for contact with blood and body fluids. If a patient is suspected to have communicable respiratory disease, it's best to use a mask that provides greater protection. Placing a mask on a patient can prevent disease transmission. Your N95 respiratory, we talked about earlier, jurisdictions may provide the treating patient with TB. Block at least 95% of airborne particles. Proper seal is necessary, and wearers should be fit to be tested. So, as I said, they're rated to fit your face. They're not universal. You can't use mine. I can't use yours unless we have the same size. Yeah. Gowns are always good. Protective expose your skin and uniform from spray, spatter, and body fluids. Especially useful in situations such as trauma and emergency childbirth. Know where they are stored and be able to don them quickly. It's ideal to keep a spare uniform with you in case something happens. Some departments may require having an extra uniform available. Soiled uniforms look unprofessional and can allow for spread of diseases. Follow department guidelines for cleaning. For extreme contamination, shower immediately and notify departments and infection control officer. Cleaning and disposing of contaminating items. It's pretty self-explanatory. Wear your gloves, get your mask, protection in place, get rid of them when you're done with the biohazards. Treat contaminated areas with designated disinfectant areas, not appropriate, splash resistance, eyewear, clean gloves, fluid resistant cloth design for decontaminating. Use of bleach and water for disinfection in accordance with manufacturing installations. I know when COVID first hit, I was up at my other fire department. We actually had a decontamination after every time we had an interception of a COVID patient. We had our little gray suits that we looked like Back to the Future. We had everything on. go outside and spray them into a little kiddie pool and then have it dispose of properly. So then they would take their little suit off. Do not decontaminate equipment or PPE in kitchen, bathroom, or living areas of the fire station. Like I said, spray. Do it outside. Do it away from high trafficked areas. That way no one takes a chance to step in on that communicable disease and getting it on theirs. Contaminated uniforms or PPE must be taken home or cleaned in a normal laundry facility. Decontaminated sink and cleaning area, remove PPE, worn during cleaning and dispose of in accordance with the code. Cleaning and disposal of contaminated items. Again, contaminated items, disposed equipment, and PPE must be placed in a medical waste container and disposed of in accordance with the protocol. Needles and blades must be placed in a sharps container. Sharps containers must be closable, puncture-proof, leak-proof, and labeled in accordance to regulation. What procedures does the term body substance isolation refer to? No, it's saying is, when someone says BSI to you, body substance isolation, what are you doing to achieve BSI? What type of PPE do responders typically use during emergency care? Gloves, or jackets, masks, possibly. Common sense is a rare thing now. Explain the process of patient assessment. Okay, I kind of breeze through this. So when you come up on a patient, you have your ABCs, airway, breathing, circulation. You want to make sure they're paid and everything. If they're talking to you, they can answer you, they're not blue, they're not cyanotic. Absolutely. If they're not able to talk to you, not that they can't talk because they're mute, but they can't talk because they're not breathing, or that's not a patent airway, that means it's not an open airway. They're breathing, how they are breathing is going to should trigger, hey, there's something going on. If they're just normal breaths, if they're in a tripod position where someone is seated like this and then leaned over, it's considered a tripod position. It opens up airway, and 9 times out of 10 people that are like this are having heart attacks. That's the most comfortable position for someone with a heart attack, because it opens up their airways. Circulation. They're not blue, they're pink, warm, dry, and pink. That's good. If they're unresponsive, it goes back to CAB. So forever, CPR used to be ABCs. Your ABCs, clear the airways, start compressions, blah, 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 blah. They've reversed that now to unresponsive circulation. You've already got oxygenated blood in your system, so you start compressions immediately. Then you check to make sure that airway is patent or open, and then you make sure that they're breathing, or if you're breathing for them. Check for a pulse. Check for brachial, radial. Assess airway, tolerable ABCs. No pulse, immediate chest compression, open airway, and ventilate rotation. If tongue or foreign object or fluid obstructs the airway, air cannot travel freely. Hopefully, if that happens, you want to turn on the left side so the secretions will come out. And if you have a hand suction or a suction device, that would help, where you put the bunker in and you only suck on your way out. You only do it for about 5 seconds. You don't have it going. And they got little holes in it, and all you got with your fingers. So it doesn't stop them as soon as you do it. Short circuit, the patient appears to talk and appears to be breathing without difficulty seeing the airways clear. If the patient is unresponsive, the airway may need to be open. So that's your head tilt chin lift. It's opening the airway. Assessing breathing, place ear near patient's nose, listen for sounds, look at the mouth. So, back 25 years ago, the American Heart Association used to do look, listen for. They don't teach it anymore, but it's still have glasses that you put over their nose, hold up at their abdomen, see if they're breathing, listen for breaths in their face. It's still a good way to assess breathing. If they're not able to breathe, if they're not breathing, there's pulses and non-responsive, then we'll start with CPR, and you're going to start with compressors. I feel like they're going to eventually go with compressors, hands-on CPR, because again, as you're compressing, there's an exchange of air, nostrils will flare and retract every time you do a compression, so there's an exchange. Is it as good quality as mouth-to-mouth or mouth-to-mask? Probably not, but it's still equality. Check for the pulse, easiest way to determine presence of circulation. You can always do the bare tones, see if the blood rushes back to it. Radial artery takes longer than body flow. Radial artery takes stronger blood flow for a pulse to be felt than a carotid. Just because a pulse cannot be found at the radial artery does not mean the patient is pulses. Attempt to find the pulse at the carotid artery. Strongest one. The hardest one, I think, is the pelvic. What does ABC's in patient assessment refer to? Describe cardiopulmonary resuscitation. CPR. Clinically death, cardiac arrest, and biological death. Clinical death or cardiac arrest. Heart stops beating. Person is not breathing. Heart fails to circulate blood through the body, and cells are not able to receive oxygen and nutrients. This can result from problems with heart's ability to produce and or transmit electrical pulses. Biological death, cell death, progresses to the point that organs such as the brain and heart are irreversibly damaged and cannot be revived. Defibrillation, outside electrical stimulation. Critical to perform as quickly as possible, but do not stop compressions in lieu of an AED. So an AED arrives, you'll still be doing compressions, and someone can put an AED on a person while you're doing compressions. The only reason you stop compressions are to evaluate the patient, to deliver a shot, the scene becomes unsafe before that patient starts breathing and talking. Advanced EMS may take the scene several minutes to arrive on the scene. Heart's condition may not warrant defibrillation, or defibrillation may not resume heart's function. So when you hook up the AED and it says no shock needed, that doesn't mean that they don't need CPR. That means that the heart is in good rhythm. AED is only going to shock a heart back into rhythm. It's either AFib or BFib, arterial fibrillation or ventricular fibrillation. Cardiopulmonary resuscitation or CPR, physically forcing the body, blood to the body, providing artificial respiration. Layman CPR is performed differently than CPR for healthcare providers. The only difference in healthcare providers and layman CPR is the T9. That's it. Layman CPR is 30 to 2 across the board. It doesn't matter if you have 5 people or 2 people. When you get into the BLS, it's 30 to 2 when it's one responder, then it goes 15 to 2 on two responders on children and infants. Adult is always 30 to 2. Become CPR certified. American Heart Association and Red Cross are considered the standard for CPR training and protocols. Your AED is already explained. Many public facilities and fire apparatus do not carry paramedics. Here in town, City Hall has one. Courthouse has one. There's one at the fire, two at the fire station. And I believe every police vehicle has an AED. I'm not 100% sure. Follow the AED prompts and instructions. AED is unsuccessful. Proceed to manual CPR. So the first thing you do with an AED is turn it on. Might be a test question. You cannot deploy an AED in water, as in you can't jump in the lake and have an AED and try and put it on. If the person's in 2 or 3 inches of water, it's not going to kill them. It's only delivered 200 joules of electricity. You try and dry them off. You don't have to have them 100% dry. You dry it until the pads get stick. Chest compressions, maintain main component of CPR. Force the heart to circulate blood through the body. Patient survivability during cardiac arrest improves with early administrations of compressions performed in different ways depending on the patient's age. So the only difference on that is an infant, you use 2 fingers or 2 thumbs encircling technique. On a child, an adult, it's still 1 or 2 hands. You have to do 1 hand with an adult to hold a wrist. It's acceptable as long as you're getting a 2-inch depth compression. On a child, it's 1.5 inches. On an infant, it's 1/3 of the anterior posterior body. Use an AED if it becomes available. Cardiac arrest, stressful for all involved. Typically unexpected. CPR may not be in progress when arriving at the scene. First priority after reviewing PPEs to determine condition of victims. CPR should not be administered to those with signs of irreversible death.
How did you know that?
Good question. Because it depends on the authority having jurisdiction. Can a paramedic call death right there, call code, or does the coroner have to come in? In most cases, but some facilities do allow the paramedics to go ahead and call. I'm just reading an article on that today. But, my best thing is if you're not a doctor or a coroner and you don't know, don't call it.
I've been in a rural situation though, where you're way out from that, you don't see the arm of the person who's dealing with it, and it's moving around. Look at this. How long can you do CPR before you become part of the problem?
Oh yeah, 100%.
You know, and wait an hour for an arm.
Right, yeah.
Keep doing it.
Right.
As you know, CPR,
Should be a short nurse
is very, it's what I'm looking for.
taxi on.
Yes.
Yes.
That's what's right.
And CPR, a lot of people are misunderstood by CPR and do not resuscitate. DNRs versus durable power of attorney. A durable power of attorney does not give you the right to tell me to quit doing CPR. And just because you tell me you have a DNR, I'm not going to stop doing resuscitation until that DNR is present. A tattoo DNR does not constitute a legitimate DNR. Yes, it has to have a signed doctor's signature, not a tattoo.
Who would have one?
There's
What, like, you're like in the wallet or something?
a DNR. I mean, your family member, your person that is going to pull the plug up, they should have that. All right, chest compressions, layperson CPR, greater emphasis on compression than ventilation. Compression only CPR is effective and provides some air movement into and out of the lungs. Full CPR is chest compression and rescue breathing. Most responders are certified in CPR to BLS for healthcare provider levels. Critical to obtain formal CPR training. I know a guy who does that. know a guy that needs, you guys need CPR. I know a guy that teaches CPR. Yeah. Chest compression for adults. Check for consciousness. Determine if the patient has a pulse. Start compression if no pulse can be found after about 10 seconds. Notify communication center of condition and sources needed. So, back up a little bit about determining the consciousness. The first thing you have to do is scene safety. Okay? Scene safety and then BSI. You look at your national registry things that we'll be doing. Top thing should be scene safe, BSI should be the top two. Those are critical fails if you don't do it. But in real life, I mean, it can be critical fails as well. BSI, scene safe. Once you, hey, are you okay? Okay, no response, check for a pulse. Pulses, not breathing, start doing compressions. Cell phones, radio, usually cell phone, put on speaker, call 911. Tell them what you're at, where you're doing. Chest compressions for adults. Make sure they're on a hard surface. You can't do compressions on the bed. Moving from the bed to the ground. Find current location and then compression. So your hand is going to be in the lower half of the breastbone, or the lower portion of the breastbone, about the nipple line. Chest compression for adults. Like I said, we're going to do 2 inches deep or 5 centimeters. I don't know anyone that hasn't been taken over. You're not going deep enough. You want to make sure that you keep your elbows locked and bend at the waist when you're doing compressions. If you try to do it just with your arms, you're going to get fatigued real quick.
If you do it wrong, you do it wrong.
I mean, possibly, but some CPR is better than no CPR. Straight arms, lock elbows, line your shoulders directly over your hands. 2 to 2.5 inches, but no further. While it may be difficult to judge the depth of compressions to greater depth may potentially harm the victim. Lift up and release the compression. So you want to make sure you allow full chest compression. As we're talking about a break, your heart, you're filling that thing up with blood really quick. The heart has no chance of getting the blood filled up into it and circulated back to it. You two breaths into the victim's mouth while holding the victim's nose closed. Don't forget to do a head tilt chin lift. Open up the airway. Do 100 to 120 compressions per minute. Continue until the patient begins breathing normally, regains consciousness, or until responders with greater training arrive or the scene becomes unsafe. Perform in a firm and rhythmic manner. Staying alive, another bites the dust, life goes on. All of them have 100 to 120 beats. Spotify has a whole, American Heart Association has a whole channel on Spotify called Don't Drop the Beat. It's got ranges from Bee Gees to Michael Jackson to Baby Shark. While performing chest compressions, it is often common to hear and feel patients' ribs break due to pressure. While sensation is not pleasant, it is a sign of quality compression and it should not discourage from continuing. This is going to get mushy. When you do compression, it's going to freak you out. No doubt about it.
So that they got to sell that back over.
Well, this is just a cartilage anyway. So it'll probably rejuvenate. I don't know.
I would like to comment on the fact that you might actually hear the bones crack.
Yeah. Chest compression for children. Again, check for responsiveness, non-response, check for the pulse. Probably the break low pulse, moving solid surface, get compression. Tell dispatch what you're doing. Larger children, you use 2 hands. Smaller children, use. Definition of child is age 1 to pubescent stages of life.
About 12.
Well, breast development on a girl and underarm on a boy. So there's some girls that develop earlier than others. Again, same thing. Push your hand in the center of the chest, do 2 inches. Administer compression, 120 beats. Breathe twice in the victim's mouth. Continue until they become conscious. Adult techniques can be used in other regard for children. Treat the child, not the age. My niece is 6 foot something. She's a woman. I mean, she's only 17 years old, 16 or 17, but she's 6 foot. I mean, by body definition, she's a woman. Chest compressions for infants are a little different. There's a lot different on an infant. Go ahead and leave this up there, but so when you're giving your breaths on adult, child, or infant, they are literally just breaths. Okay, on an infant, it's more of a whisper. It's like on a child and an adult, it's just a regular. You don't have to be Superman or Superwoman and do these big super breaths. You just want the chest to rise. If you blow too hard and too fast, you get into the GI system on adult, child, and then whatever's in there is coming up. If you don't have a pocket mask, you're going to have it in your mouth. On an infant, if you blow too hard, you're going to blow out their lungs because they're not developed yet. Absolutely.
You're doing it on an infant. I'm going to ask you this with the CPR guy. Okay, the way I learned it, it's like this.
Yes.
Instead of.
Yes, when you do your compressions, they do now 2 thumbs, bring that with you. They do 2 thumb encircling technique where you grab the baby like that. They used to only teach that on the BLS side, but now they've incorporated it into the layman side. Or you use your 2 fingers. So, as the baby's laying down, turn it on so you know.
Isn't that pretty much so also, I mean, say a baby, but if it's a small child, you know, let them be like 3 or 4 or 5 years old. See how big they are.
See, that's too fast. Or you can. Put your thumbs.
Okay, I've never seen that before, but I've done that.
This is called the 2 thumb encircling technique. Much more efficient, in my opinion, and way more comfortable. So again, too hard on an infant, you blow out their lungs. When you do your mouth to mouth, it is actually mouth to nose on an infant. Your mouth, it's mouth to nose. You're covering their nose and their mouth at the same time. Head tilt, chin lift when you give that breath, or that whisper of a breath. If you don't see the chest rise, don't worry about it. Get back to compressions. You may, as you head tilt, chin lift, maybe pinch it off their airways. When you get into adult and children and do a head tilt, chin lift, you want to get onto the bone and only stay on the bone. Because if I tilt back and then I get back here, I start cutting off my airway. And so your breaths aren't going to be delivered as well.
And I also want to comment that this is always necessarily so a really professional situation, like doing the back of the ambulance. But in spite of all of these things he was teaching, you could have seen an accident and you're doing CPR and it's complete chaos.
Oh, yeah.
It's probably more from your intuition or your own problem thinking out and probably something, isn't it?
Yeah. We went over the chest compressions for infants. And I said earlier it's 1.5 inches, or 1/3 of the anterior posterior. What's the purpose of performing chest compression during CPR? Why do we do compressions? No, why do we do compressions? Circulation. How is the procedure to perform chest compressions for infants and young children, victims, and adults?
Or maybe the thumbs like he said.
Right.
Well, that's 2 fingers.
Right, yeah.
I was always talking forward.
Yeah, that's what they've always thought. Like I said, in recent years, they've incorporated in layman that you can now do. Because on the BLS side, they've always said you can use the when you go to two-person, you use the two-thumb circumcision. I had someone ask me one time, well, why can't we do that normally? I don't have a rhyme or reason why you can't. Why you should discontinue CPR. Patient moves or regains conscious. Patient has a pulse. Patient breathes. You hand over care to rescue with higher level training. Physician instructs you to stop. Discontinue cardiac emotions, especially if the patient's family and friends are present. There is nothing, and I mean nothing, like having family members stand over you. Save my mom, save my dad, save my grandpa while you're doing CPR. You're like, holy shit, I hope I don't screw up. I hope I get this person back. You may be subject to anger when deciding not to begin CPR or when to continue CPR. Speak calmly to family members and friends of the deceased and keep their feelings in mind when discussing the patient with others responsible.
Let me ask, do doctors and nurses know how to do CPRs or usually just do like the EMS?
No, they have to have it.
Okay.
They have to have it for their license.
Okay.
They have more advanced. So CPR levels is layman CPR, BLS, basic life support, advanced life support, and there's another whole cardiac, ACLS.
Okay, so the nurses, the doctors, and the ER have to do CPR?
Yes.
Okay.
Yeah, so in an ER, whenever a code happens, you have people from almost every division of that hospital come down to that code. I know this because when I did one of my clinicals in Liberty, that's what happened. I was doing compressions, another nurse student was helping with compressions. They had people from cath lab, people from respiratory, I mean everybody, and they have certain bags that everybody grabs. It's really amazing. At what point should you discontinue CPR?
They regain consciousness or try to work.
Describe methods of controlling bleeding. Blood transports oxygen and nutrients to cells, maintaining blood flow and volume in extremities, extremely important. Be prepared to control the victim's bleeding. Occurs outside the body, that would be why it's external bleeding and not internal. You have lacerations, punctuations, and abrasions. Abrasions or bruises, punctuate, or just a stab or laceration with a cut. Arterial bleeding, if it's squirting or hurting, get a tourniquet. Our arteries transfer blood away from the heart. Blood in arteries is bright red under pressure. Arterial bleeding occurs when the artery wall ruptures. Bright red, burning, forces decrease in significant blood loss, often difficult to control, true medical emergency. Don't delay transporting the victim. Get a tourniquet on quick. And if that first one doesn't work, go to the second one. You can't, when you place tourniquets, you don't place it on the wound, you go from 2 to 4 inches above the wound and not on a joint. If that one doesn't work, we're going to apply another one on top of it. The venous bleeding, these are your typical veins.
There is an exception to that on the tourniquet though. If they've got like a cut off their head.
Yes.
Don't put the tourniquet around.
Can't put them around their neck. Typical, easy to control. These are your.
She's a blonde.
Oh boy, I'm leaving.
Hey, it's box one, not real one, right?
Right, capillary bleeding. So areas between the arteries and veins where oxygen, nutrients, and blood are delivered. The cap refills is what I was talking about earlier, where you pinch to see if blood comes back from circulation. Blood moves relatively slow. Capillary bleeding, most increase to capillaries are scrapes, superficial lacerations, limited quantity of blood. Can stop without interventions. I had a cut the other day, I probably need stitches.
You know, he says he got a paper cut that's what his finger and it hurt like hell.
Oh, yeah. What are 3 types of external bleeding?
Puncture.
Arterial.
Abrasion,
Laceration.
laceration. Provide an example of each of the following types. Arterial. Pretty self-explanatory.
Artery.
Yeah. Venous. Yeah. That's your heart. That's your heart. Artery squirt. Veins. You might cut a vein, but it's not. It's a little easier to control. And then capillaries. Yeah. Right. And capillaries are the slower ones. So that's like the little nicks you can get that you control. Controlling external bleeding, supply pressure, and stacking of gauze. Elevation, combination of both allows protocol standards, proper PPE to be used in treating gloves, shields, masks needed. Train medical professionals use tourniquets to stop blood loss. Direct pressure, apply pressure with blood tan dressing, if blood soaks through, put another one on there. So what they're teaching now in EMT school, that used to be the basics of it, it's the guidelines. Put it on there, put it on there, put it on there. They say now, if you put it on and it bleeds through, get a tourniquet and put it on. I say use your own judgment, because it's just a little cut and you got that much gauze and it's gonna bleed through it. Continue until blood pump ceases to seep through. Apply bandage to hold the ceiling in place and keep pressure on. The only way I know about trying to get one gauze is the UMKC when I went through EMT school. We were doing skills and that's one of the things I had to do. And I said, apply pressure, look, see if it's still bleeding, put another one on there. And airman goes, oh no. You're old. That's probably. He goes, we don't do that anymore. We just put pregnancy on that. What pressure does, blood can be lost quickly, no time to be wasted. By dressing and bandages that can be located and open. Don't apply until you stop bleeding. Using.
Can you use stitches in an ambulance?
I can't.
Okay.
I think you could with bleeding. Yeah.
Well, I just wonder, I mean, if someone was bleeding out there.
That's out of my scope of practice to do stitches in general.
Okay. That's only what you do to the doctor's office. In the hospital.
Yeah. Using conjunction with correct pressure, injuries for extremity, you put your arm up. Gravity helps slow bleeding, may not be possible in some instances. Sears. Yeah.
What is it? Pressure and
And gravity. Internal bleeding may occur when blood vessels rupture. Spaces in the body can hold a considerable amount of blood before there is evidence of the problem. Cannot be seen extremely. Signs and symptoms, significant bruising or other indications of injury, especially involving the patient's torso. It's usually called bleeding. Blood is up there. Bleeding from openings such as mouth, nose, and rectum. Bloody stool or urine, painful swelling or rigid abdomen. Vomiting of substances resembling coffee grounds. Cool pale clammy skin. Traumatic causes include gunshot wounds, stab wounds, motor vehicle accidents, or falls. Medical causes include rupture of blood vessels or organs. Controlled internal bleeding is medical emergency. Treat the patient for shock and immediately transport the patient to a closest facility. What are signs and symptoms of internal bleeding? Yeah. What's the signs and symptoms of internal bleeding?
turning blue, bruising. What is doing?
Explain shock management. Shock is the body is unable to regulate itself and maintain normal function. Body is unable to supply enough blood to vital organs three types of shock: hypovolemic, cardiogenic, and neurogenic. So the prefix hypo, blood. Or I'm sorry, hypo is breathing. Cardio, blood, yeah, heart. And then neuro, mind, nerves. Causes of shock, trauma, other medical emergency, anaphylactic reactions, or septic. The types of shock: hypovolemic, patient loses substantial amount of blood. Body is unable to supply blood to it is unable to supply blood to the tissue. The volume of the blood, majority of shock instances are hypovolemic. Cardiogenic shock: heart is unable to force enough blood to tissue for its function. Lack of supply is the pump. So hypo is your vessel, the veins. Cardio is your ship, your boat, right? Or your pump. Myocardial infarction, MI, may cause heart attack and apparently can cause cardiogenic shock. Neurogenic shock: blood vessels expand and contract due to brain signals and regulate blood flow. Occurs when there is damage to the brain, spinal cord, or other nerves that regulate blood vessels. Typically a result of over expansion of blood vessels and decreased blood pressure. Container issue, commonly caused by spinal trauma and head injury.
That's a lot to take in on this guy.
Types of shock: anaphylactic shock occurs when a severe allergic reaction happens. Septic shock or sepsis results in severe infection. These two are not as common as other types, but still dangerous and should be treated in medical emergencies. What are the three types of common types of shock? Signs and symptoms of shock: internal body functions are carefully adjusted to achieve optimal results. So, negative condition happens, the body adjusts, the body may not be able to maintain normal operations, and the body gradually exhibits negative effects of the condition. That's how it progresses. Signs and symptoms of shock: pale fluid, moist skin, rapid heart rate or tachycardia, rapid breathing or tachypnea, nausea and or vomiting, confusion, altered mental status, dizziness, dilated pupils, and loss of consciousness. So the generation that's walking around right now. That's them. What are some the signs and symptoms of shock?
Dizziness and nausea. Pale skin.
Pale skin, clammy, yeah, it's a whole message. Treatment for shock: patients exhibiting signs and symptoms of shock should be treated immediately and prepared for transport. Paramedic treatment is important, but should not be delayed to hospital. Transport to the hospital is best treated. In most cases, should never be delayed. Treatment for shock: keep the wounds and injuries elevated if possible. Oxygen should be used within local protocols. Control bleeding immediately. Cover the patient with a blanket and maintain body temperature. EMTs and paramedics provide advanced treatments. So what should you do if the patient goes into shock? You can be walking around with shock. I'm going to keep you warm. Might elevate your legs. Might give you oxygen if you need it.
So the shock is the beginning of the dying process.
Yeah.
It's surprising that proclamation
So can you reverse it?
Yes. Are there any questions or comments?
So what to take in?
That's the end of that.
Can I see that?
You-
Don't take a break.
No,
First, let's see that.
we're going to take a 5-minute break just so I can get the oxygen and everything ready, and then we'll go over the test. We'll go to the test, take a real quick break, go to the oxygen so I can show you guys how to do the oxygen. Alright, so we're going to go over skills real quick on this. National Registry, oxygen administration by non-regulated. First thing you want to do is check your regulator, make sure the O-rings are fine, make sure that there's nothing interrupting it or disrupting it. Got two little prongs, two little bolts. Tighten it on there. Always want to maintain at least one hand on this if you don't ever leave it standing up. Lay it down. If you're on a cot or whatever, just stand it up, leave it down. Don't. If you're not paying attention to it, knock that off, which becomes a bomb. Miss it. Yeah. Always bleed it before you attach anything. Make sure that you have oxygen. Turn it on first. Check it. Red, green, full, empty. Full, empty. Once it's on, bleed it. Make sure there's nothing obstructing it. I'll let you know if you got it connected, right? Cracks valve up, send the regulator. Just did that. Open the tank. Checks the tank for pressure. Checks the leak. Now we're going to attach the non-rebreather. Little tank. Slides right on there. Once you have that assembled, turn the oxygen on, flow to fill the reserve tank. Okay? You want to turn it up to 15. When you do that, you want to make sure you plug this hole to keep this bag in. We'll go 15. And the bag. Just the regulator to assure oxygen flow rate of at least 10 liters per minute. You have numbers right here on the side. And then attach it to the mannequin. Form it up. Very tight. CPR. Going over it. Hands in there. Make sure you always take the BSI. Stay safe. Check the patient response. Hey, are you okay? Are you okay? Get an AED and come back. Always tell people to come back because you don't know what happens in their life. Request additional EMS. Ask if you have everything you need and so stuff for there. We'll go over this test. And then take it. And we'll knock out the skills and we'll be done. Alright, so no matter what kind of ambulance service is provided in a jurisdiction, it is important that firefighters respond to every medical call, train regularly with EMS personnel, have the same level of medical training, or know how to drive the ambulance if it becomes necessary. No, these are your questions. So, it's important for firefighters to no matter what kind of ambulance service is provided in the jurisdiction, it is important that firefighters respond to every medical call, train regularly with every personnel, with EMS personnel, have the same level of medical training as EMS personnel, or know how to drive the ambulance if it becomes necessary. No, these are the things.
Oh, is there one answer?
Yes.
Oh, okay.
Which one of these?
Oh, okay, ask again. Because
Are we answering them out loud?
Yeah.
Okay,
We're
okay.
going over.
Oh,
important that firefighters respond to every medical call, train regularly with EMS personnel, have the same level of medical training as EMS personnel, or know how to drive the ambulance.
Number 2.
Yep. What does Health Insurance Portability and Accountability Act regulate?
Patient's privacy and health requirements.
Does it regulate protected medical information, type of care provided in incidents, first responders personnel, personal information, types of health insurance accepted by EMS providers? Which communicable disease attacks the liver and can cause yellow?
Hepatitis.
Yeah, this color very stupid. Yeah. Woo. Which would you be an example of a responder? Which would be an example of a responder using body substance isolation, BSI? Triaging patient by their level of injury, assessing the patient vital functions using the ABC method, visiting rehabilitation station frequently during the EMS call, wearing gloves and masks while treating potential.
Yes, that one. What she said.
The ABCs of patient assessments refers to the easiest way to determine the presence of circulation is to
Check for a pulse.
when a patient is considered clinically dead?
But they have had a pulse on how long?
Or no pulse and
Not breathing. Does it say for a specified amount of time?
no.
This is what.
Clinically dead, you're not, DRT, they're dead right there. They're not breathing, they don't have a pulse. What is the first step when you're performing CPR on an adult?
Compressions.
Place down on the victim's chest.
Check your.
Breathe twice in the victim's mouth. Place hands on the victim's
You
chest.
check for a pulse or something, don't you? What you do?
Tilt the victim's head back and open the air.
Compressions.
When you're doing adult.
Hey, are you okay?
Yeah, this is a trick question because it is tilted back and open the airway. But if you're doing compression, it's CAB, not ABC. For this instance, it says tilt the victim's head back and open for his or her airway.
That's the correct answer.
That is the correct answer. When performing CPR on a small child, the rescuer should only use one hand of compression. Perform CPR the same as an adult.
Only this one.
Do rescue breaths, not chest compressions. Patients with blank bleeding may lose a great deal of blood in a short time and should be quickly transported to the hospital. Arterial, lateral, venous, or capillary. Pale, clammy skin, significant bruising may be signs of blank bleeding. Which type of shock occurs as a result of damage to spinal cord and other nerves that control and regulate blood vessels? Neurogenic. What sign is the patient? What is a sign that a patient is possibly in shock? Slow breathing, slow heart rate, pale and moist skin, red blotchy skin. Slow heart rate.
That's an easy test.
No, that has nothing to do with me failing to breath.
don't miss it,
You said it was slow heart rate.
I know.
You're gonna get, oh yeah, they could be all.
I think it could too, yeah. I think it's gonna be the opposite.
I'm doing the post, so put your music, you know.
Be always trying.
Some of it is common sense, though, too, you know? It's really annoying when you have common sense, and you keep it around,
We will, we're gonna, I'm going to take those from you when we do the skills.
So are we certified in CPR now?
No, but I can certify you. If you knock this out. It's technically.
Can you give a CPR to a dog or animal?
Yes.
Yeah. Is it
You
the same?
give oxygen to them.
Yeah, I've seen that done to the dog.
No, I
It's
don't.
a hot fire. Yeah.
Oh, yeah.
Well, the carriers, they make masks for all.
They actually do, yeah.
Well, there's a dog that could be in the car wreck and be traumatized and stuff too, you know? A fire, yeah. Because they were saving dogs from fire down here.
Yeah. Julie applied oxygen to them and it helped.
Isn't she the one that goes to like every fire call?
Yep. Well, she doesn't have a full-time job.
Okay, we're gonna go ahead and move on to the skills. We'll let Kim go first. Let's say go home and go to bed.
I'm so tired, guys. I'm sorry.
I gotta drive to Kansas City in the morning.
Oh, yeah.
Does that count?
It's their time much cheaper than my dogs.
I gotta go.
I could go last.
I'll be up there all night. We shut it in.
Well, in the morning, so I'm going to the city. I got to drive all the way.
Sometimes we have all our stuff's ready to go, so.
We're gonna do oxygen first, okay? Look over that real quick.